Welcome to this Step 2 clinical knowledge review on informed consent and capacity test-taking strategies. This video is brought to you by Roadmap to Residency. Today, we are breaking down the most common question patterns you will encounter on your board exam for informed consent, capacity assessment, advanced directives, and surrogate decision-making. The goal here is not to reteach the entire ethics curriculum, but to help you recognize high-yield patterns and apply test-taking strategies so you can pick the right answer quickly and confidently. Make sure you have reviewed the ethics and legal sections of first aid and your question bank before or alongside this video. Here is what we will cover today. First, we will learn to recognize the high-yield question stems for informed consent and capacity that show up on board exams. Second, we will apply specific test-taking strategies for questions about capacity assessment, advanced directives, and surrogate decision-making. Third, we will master the next best step question format for ethical and legal clinical scenarios. Before watching, make sure you have gone through the ethics and behavioral science chapters in first aid and completed practice questions in your question bank. This video is about applying that knowledge strategically on test day, not relearning the basics. Let us start with the informed consent checklist. On the boards, informed consent questions come down to knowing the 5 required elements. The patient must receive disclosure of the diagnosis and prognosis, a description of the proposed treatment, a discussion of alternatives including doing nothing, the risks and benefits of each option, and confirmation that the patient understands. If any STEM asks whether consent is valid and one of these elements is missing, the answer is almost always that the consent is not complete. Now, the boards also love testing exceptions. You do not need formal consent in a life-threatening emergency when the patient cannot communicate. Implied consent applies to routine, non-invasive exams, and involuntary psychiatric holds bypass standard consent when a patient is a danger to themselves or others. When you see an unconscious trauma patient in a STEM, always think emergency exception and treat first. Now let us talk about capacity assessment, which is one of the most heavily tested topics in the ethics section. Capacity has 4 criteria. First, the patient must be able to communicate a choice. Second, they must understand the relevant medical information. Third, they must appreciate how the situation applies to them personally. And fourth, they must be able to reason through the options. The boards love to test the difference between understanding and appreciation. A patient might repeat back the information perfectly, but fail to grasp that it applies to their own situation. That is a lack of appreciation, and it means they lack capacity for that specific decision. Here is the big pitfall. Capacity is decision-specific, not global. A confused elderly patient might lack capacity for a complex surgical decision, but can still refuse a blood draw. And very importantly, disagreeing with the doctor does not mean a patient lacks capacity. If you see a STEM where a patient refuses treatment and the doctor wants to override them, check whether the patient meets all 4 criteria first. If they do, the answer is to respect the refusal. Let us go through the 3 high-yield STEM patterns you will see. First, the informed consent STEM. You will see a physician about to perform a procedure, but the patient was not told about alternatives or risks. Whenever a required element is missing, the answer is to complete the informed consent process. Do not proceed until all 5 elements are covered. Second, the capacity challenge STEM. A patient refuses treatment, and the physician is worried the patient does not understand. The next step is always to formally assess capacity. It is never to override the patient, call psychiatry without assessing first, or sedate them. Third, the surrogate decision STEM. An incapacitated patient needs a medical decision and has no advanced directive. The boards want you to know the hierarchy. Healthcare proxy first, then spouse, then adult children, then parents, then siblings. The surrogate should use substituted judgment, meaning they decide based on what the patient would have wanted, not what the surrogate personally prefers. Here is our first practice question. A 55-year-old woman is scheduled for an elective cholecystectomy tomorrow. The surgeon explains the procedure and its risks. The patient agrees to surgery, but then asks if there are other ways to treat her gallstones. The surgeon says surgery is the best option and asks the patient to sign the consent form. What is the most appropriate next step? Take a moment and think about which element of informed consent is missing here. The answer choices are A. Proceed with surgery since the patient already agreed. B. Discuss alternative treatment options with the patient. C. Have the patient sign the consent form and address questions later. D. Ask the hospital ethics committee to evaluate the situation. Let us walk through this answer. Step 1. Spot the pattern. The patient is asking about alternatives. That is your red flag. It tells you that the discussion of alternatives, which is one of the 5 required elements of informed consent, was never addressed. Step 2. Apply the rule. Informed consent is not valid until all 5 elements are covered: disclosure, proposed treatment, alternatives, risks and benefits, and patient understanding. If any element is missing, the next step is always to address that gap before moving forward. You never rush past a patient who is asking questions. Step 3. Eliminate wrong answers. Choice A says proceed because the patient already agreed, but agreement without full information is not valid consent. Choice C says sign now and address questions later, but that defeats the purpose of informed consent. Choice D says call the ethics committee, but this is a routine consent issue, not an ethical dilemma. The correct answer is B, discuss alternative treatment options with the patient. Here is our second practice question. A 70-year-old man with diabetes and a gangrenous foot is recommended for below-knee amputation. He says he understands the infection could kill him, but states he would rather die than lose his leg. He calmly explains his reasoning and describes his values. His family is upset and asks the physician to override his decision. What is the most appropriate next step? Think carefully about the 4 criteria for capacity here. The choices are: A. Proceed with amputation per the family request. B. Consult psychiatry for a competency evaluation. C. Respect the patient refusal and provide comfort measures. D. Obtain a court order to proceed with surgery. Let us break this one down. First, assess the 4 criteria. This patient communicates a clear choice. He would rather die than lose his leg. He understands the medical information. He knows the infection could kill him. He appreciates how it applies to him. He is making this decision about his own body with full awareness of the consequences. And he can reason through the options. He calmly explains his values and logic. He meets all 4 criteria for capacity. Now, here is the key test-taking pearl. A patient with capacity has an absolute right to refuse any treatment, even life-saving treatment. The family cannot override this. You do not need a psychiatry consult when the patient is clearly demonstrating capacity, and a court order is inappropriate when there is no question about capacity. The answer is C, respect the patient refusal and provide comfort measures. This is a classic board question designed to test whether you will protect patient autonomy even when the outcome might be death. Now let us cover advanced directives, another high-yield topic. There are 2 main types you need to know. First, the living will, which is a written document where a patient specifies what treatments they want or do not want if they lose capacity. Second, the healthcare proxy, also called durable power of attorney for healthcare, which is a person the patient designates to make medical decisions on their behalf. Here is a critical board rule. When there is a conflict between the living will and the healthcare proxy, the proxy wins. Why? Because the proxy can interpret the patient wishes in the context of the actual situation, which a static document cannot do. Now here are the rules the boards love to test. Advanced directives only kick in when the patient lacks capacity. If the patient is awake and has capacity, their current wishes override any prior directive, period. A patient can change or revoke their advanced directive at any time while they have capacity. The classic board question is a patient who previously signed a do not resuscitate order, but now tells the team they want to be resuscitated. The answer is always to follow the current wishes, not the old document. Here is practice question 3. A 45-year-old man is in a coma after a severe stroke. He has no advanced directive and no healthcare proxy. His wife says he would have wanted everything done to keep him alive. His adult daughter says he told her he would never want to be kept on machines. His mother agrees with the daughter. Who is the appropriate surrogate decision maker? Think about the hierarchy of surrogate decision makers. The choices are A, the hospital ethics committee, B, the wife, C, the adult daughter because she has direct knowledge of his wishes, D, the mother. Let us walk through this answer. The key here is applying the surrogate hierarchy. When there is no advance directive and no designated healthcare proxy, you follow the legal hierarchy. Spouse first, then adult children, then parents, then siblings. The wife is first in line, so she is the default decision maker. Now this question is tricky because the daughter claims to know what the patient actually wanted. This is a classic board distractor. The daughter may have valuable information, and ideally the family would discuss this together, but the legal authority belongs to the spouse. The surrogate should use substituted judgment, meaning they decide based on what the patient would have wanted, not their own preferences. But the hierarchy determines who gets to exercise that judgment. Choice A is wrong because the ethics committee advises on disputes but does not replace the surrogate. Choice C is wrong because having direct knowledge does not jump you ahead in the hierarchy. Choice D is wrong because the mother falls below the spouse. The answer is B, the wife. Let us close with a critical test-taking pearl about surrogate decision-making standards. There are 2 standards the boards want you to know. First, substituted judgment. This means the surrogate decides based on what the patient would have wanted using their known values, prior statements, and beliefs. This is always the preferred standard when any information exists about the patient wishes. Second, the best interest standard. This is used only when nothing is known about what the patient would have wanted. In that case, the surrogate should act in the patient-objective medical best interest. The boards love testing 3 scenarios. If a patient previously expressed wishes, even informally, use substituted judgment. If nothing is known about the patient values, use best interest. And if the surrogate and the medical team disagree on the right course, the next step is usually an ethics committee consultation, not jumping straight to a court order. One more thing, minors are a special case. Parents generally make medical decisions for minors unless the minor is legally emancipated or the situation involves an emergency, sexually transmitted infection treatment, contraception, or substance use treatment. These exceptions are heavily tested. That wraps up our review of informed consent and capacity test-taking strategies for Step 2. Remember, the boards are testing whether you can apply these principles, not just memorize them. Go back to your ethics and behavioral science chapters in first aid and work through the related questions in your question bank. Focus on the elements of informed consent, the 4 criteria for capacity, the rules for advanced directives, and the surrogate decision-making hierarchy. If you found this video helpful, please like and subscribe to our channel for more high-yield board review content. And if you want personalized help with your board prep or residency applications, check out our expert tutors and residency advisors at roadmap2residency.com. We are here to help you succeed. Good luck on your exam, and we will see you in the next video.